So why survivorship? And I'm all about stories, so you're going to get a story. And my little things, you'll notice this person with all those little barriers. They're not jumping over the hurdles. They're knocking them down. You'll see why with this next case. Oh, do we not have the one with the cases in it? No, we don't. All right, let me grab my notes and I'll read you the case. There is a set of slides, I promise you, that was in it, that does have the cases. If you guys get me reading them instead, and that'll be even more fun, I promise. So good thing I brought that set on paper. So my first case then is this 32-year-old gentleman, and he was diagnosed, he had onset of fatigue and chest discomfort at 32 years of age, and it was, it ended up that he had a primary mediastinal seminoma, and so he had this whole series of complications, all of these hurdles that he didn't jump over, that he just kind of plowed through. During surgery, a vein was nixed with his biopsy, and then when he had his official surgery, the phrenic nerve and the right lung was damaged when they opened the chest. He went on to have chemo and radiation, from which he had significant esophageal dysfunction. Then he had to have his sternum removed because of infection and multiple infections, and unable to get that under control, had numerous skin grafts after that. He developed a significant doubt and mistrust of the medical system, right, after all of that. And then he went on over the next couple of years to develop depression, rage, post-traumatic distress, and huge family distress. Was separated from his wife and his family, came back together again. Lots and lots of relationship and family distress. Well, this gentleman was a pediatrician, and so this is somebody who even knew the medical system and went through all of this. And he's now 75 years old, and we know him as the father of survivorship. And his name was Fitzhugh Mullen. And Fitzhugh Mullen is really kind of this person who came up with this. His very first article in the New England Journal about this was called Reflections of a Physician with Cancer, Seasons of Survival. And Oncology Nursing Society will have a book that's actually in final publishing review right now that's going to be based off of his idea of seasons of survival and looking at cancer care all the way through survivorship from a nursing perspective, so watch that on your ONS feeds. But he says, it's as if we have invented this sophisticated technique to save people from drowning, but once they've been pulled from the water, we leave them on the dock, spluttering on their own in the belief that we have done all that we can. And he really believes that there was a lot more we could have done for him as a cancer survivor, and has gone on to really be the spearhead behind the Commission on Cancer's survivorship mandate. And he says that survivorship should be studied as a phenomenon in itself, rather than just this afterthought of basic research on cancer treatment. So how do we address the needs of these cancer survivors? So there's a couple of different organizing bodies that have said, you know, we really need to do better than we're doing, and we're going to make sure you're doing it, darn it. And so the big one is this American College of Surgeons Commission on Cancer. And in their Chapter 3 of their standards ensuring patient-centered care, they say that we should be doing genetic testing, we should be doing survivorship care plans, and we should have a mechanism to address psychosocial distress and healthcare disparities and barriers. And so these are things that we're all supposed to be doing in our accredited cancer centers, and we're doing it to some degree of success, but probably not anywhere near how far we should be doing it with any of these to actually fully meet our standards. So this COC Standard 3.3 on survivorship care, it really does say that we're supposed to be doing this. This treatment summary and care plan is going to go to the patients at the end of treatment, and they actually have a timeline with that. It's supposed to be 12 to 18 months after diagnosis. So I know in my particular center, I've been told by our breast oncology group that survivorship can see their patients after they've completed their 5 years. Well, that doesn't meet the COC guideline. And so now we're kind of in a debate on how do we implement survivorship care, but maybe not step on the toes of surveillance. So sometimes there's things in place, but it's not in place super well. That we're supposed to be providing some advocacy and care coordination, and that these particular things are in the document. One of the things that's in that COC standard, it says that cancer survivors should be provided with a comprehensive care summary and follow-up plan that is clearly and effectively explained. And another place where we're kind of falling down on this standard is we're hitting print off of Epic or like filling in some things on the ASCO template and mailing them to patients or sliding them across the table at people in a packet of other things. And then we're checking the box and saying that we're doing survivorship care or we're providing a care plan, but we're actually not really meeting the letter of the accreditation standard by doing that. The other group that's after us or advocating, whichever way you want to look at it, is the Center for Medicare and Medicaid Services, and they're looking at meaningful use. So they're not really so much about are we providing this treatment summary and care plan and giving it to people at this certain time and everything, but they're saying what actually it has shown to be meaningful, and you, cancer provider, are you doing that? And one of the components they say is that these survivorship treatment summary and care plans are considered meaningful and necessary. And my thought is that nurses are in a great position to do this and provide that service for their institutions to meet the CMS requirement, but actually then incorporate those COC guidelines and do that in a way that truly is meaningful for the patients. My worry is that CMS is going to come through and say you need to be doing this, and sure enough, somebody in some dark room is going to print off a treatment summary care plan and mail it, and they're going to say, yes, we've met our meaningful use, and on paper it will look that way, but really for the patient it won't. So this is going to impact the bottom line, so we're going to be hearing more and more about this survivorship thing, and I can tell you right now it's going to be the really rare physician who is going to be providing this. So whether you're a nurse practitioner or a PA or an RN or an LPN or the nurse navigator or the unit secretary, somebody's going to be roped into doing these things, because there is going to be a 4% reduction in payments starting in 2019 from the review that they did in 2017. And once that hits, it's just going to go up, because it can go up to 9% of a reduction in payment by 2022 if there's low scoring providers or institutions. So let me tell you, when they get that first big hit in 2019, next year, somebody is going to be waking up and barking to get these treatment summaries done. And hopefully our job is to make sure that those are done with quality. There's also going to be an increased incentive if you get it right. And so that's where I think it's going to be coming around. And survivorship care is meaningful. These are unsolicited comments that have come on just comment cards from patients. And these are one of those things on the burnout talk. I have to say I collect these and I just keep them in a file folder. And some days I just open up my file folder and go, yeah, that's why I'm here. But I really love this. After my cancer treatment, I knew there were tests I needed and illnesses I was indeed at risk for, but I didn't know the specifics. Now I know exactly what I need to do to be as healthy as possible for the future. That's what we want. That's the meaningful use. That's the empowerment. And I love this. It's the formerly missing step to help us survivors regain our dignity and confidence, moving forward with our eyes wide open. Our patients want to know if the anthracycline can cause them cardiomyopathy down the road, because then they've got an incentive for a heart healthy diet, quitting smoking, getting a walk in, and being there for their kids when when their kids are growing up. And if they don't know the why behind what's going on, if we're just exercise and a heart healthy diet, they're like, right? But if they know why, that they were actually given something that has that potential to cause them trouble down the road, or that they need to be looking for secondary skin cancers after radiation, or if their esophagus starts to get tighter, that they can go in and have a dilation done and they don't have to choke at the dinner table every night. If they know to be watching for that and be proactive, it makes a huge difference in their lives. So what are these models of survivorship care of which I speak? So we all work in different areas. This is institution-based roles that I'd like to propose. Nurses can be embedded in each service line, and they are, from diagnosis with all patients. And that gives nurses this unique and amazing ability to start maybe creating that treatment summary care plan from diagnosis. What's their pathology? Who have they seen? Did they get a second opinion? What's their treatment plan? What were their side effects that might have changed their treatment plan over time? And then you're all set up and ready at the end of treatment to say, here's your treatment summary and care plan that summarizes all that in a little bitty bite. And I've been there for all of that, so I can talk you through this. So that's one way. There might be a specific population focus. So at SCCA we have our long-term follow-up group in transplant that specifically just works with that group. I actually see a lot of the transplant patients in survivorship now, but that's new over about the last 3-4 years. And but working in a particular group where that's something you know, and maybe you see all the breast patients, not just the ones that you walk through treatment with, or all the transplant, or all the renal melanoma. There can also be nurses as a treatment team member that just provides the treatment summary and care plan at the end of active treatment. Maybe that is your role. Maybe you're not